Good day, I'm Anna Nolte and we're busy with the adaptation of the normal newborn baby, and we are busy with lesson 2. We've already talked about the adaptation in the respiratory and the circulatory system and the metabolism, and this part of the lesson 2 we are going to talk about the other body systems, for example, temperature control and bilirubin metabolism. Now, first of all, when we look at the thermal adaptation of the newborn baby, we've said in the previous lesson that during birth, rapid cooling happens because he comes from a body temperature environment into a cooler environment, and then also he's wet from the liquor, amniotic fluid that sits on his skin, and evaporation causes that he loses a lot of heat in the process. Now, heat loss, if we look at heat loss in general in a newborn baby, there's certain characteristics that predispose the newborn to lose heat. First of all, his skin is thin and the blood vessels are close to the surface. So obviously he will lose some heat from the blood vessels that's very close to the surface. Secondly, he has very little subcutaneous fat or white fat, and that also normally presents a barrier to heat loss. Now, in the absence of this, again, the blood vessels are being exposed, and it's very easy for him to lose a lot of heat then. And heat is also readily transferred from the warmer internal areas in the body to the cooler skin surface, and that also makes him to lose a lot of body temperature. The other problem is that they have 3 times more surface area to body mass than we adults have. So it's a much larger area for them that's been exposed and that they can lose heat from. Now, a full-term baby usually lies in a position of flexion, and that reduces the amount of skin surface that's been exposed to the surrounding temperatures to a certain extent. But in the case of sick and preterm and asphyxiated babies during labor, they have decreased muscle tone and they're not lying in this flexed position, so a bigger area of their bodies are being exposed, and obviously helps with loss of temperature. And then preterm infants are prone to all this, plus they also have a thinner skin and even less subcutaneous fat. Now, we've said that babies lose heat very easily, but it's also very difficult for them to produce heat. They can't shiver very little, so this is not really a way for them to generate some heat. Instead, they become restless and they cry, and that increases their body activity, first of all, and that generates some heat. And also the fact that they're in a more flexed position help to expose less surface area so that they lose less heat. Now, in addition to the drop in temperature and all their efforts to generate some heat, it increases the metabolic rate up as much as 200 to 300%. And this causes above normal oxygen and glucose use. And this is extremely important to us because specifically in asphyxiated babies and babies with respiratory distress that really seriously need the oxygen, they can't afford to lose more oxygen in the process of trying to produce heat. And as we've said, glucose, as it is very scarce in the newborn baby. So again, also they can't afford to lose more glucose to heat production. Now, a very important part in the heat production process of babies is brown fat. That's the primary method of heat production, and we call that the non-shivering thermogenesis because it is being the heat is being generated by the metabolism of brown fat, and you can see the brown fat is lying here primarily around the back of the neck and the axillas, and also here in front around the heart, the kidneys, and the adrenal glands, around the scapulars as well. And they are being called brown fat because they have an abundant supply of blood vessels, and that causes the brown color. Now, the moment that the baby is now being cold, as we've said, it stimulates the hypothalamic thermal center, and that causes the more blood flow to the brown fat, and the brown fat is being warmed and carries the blood flow can carries the increased heat from this brown fat to the rest of the body. But as we've said, this use a lot of increase the metabolic rate a lot, and that uses a lot of oxygen and as glucose, as we've said. Now, cold stress also causes a diminished production of surfactant. Now, we have said that even after the birth of the baby, there's still surfactant being formed. So if the baby is being cold, it diminishes the increase of that production of surfactant, and that has obviously an effect on the lung expansion, and that can lead to more respiratory distress. Now, we have said that heat production not only uses more oxygen, as we've said here, but then also it uses it prevents surfactant formation, which increase then the possibility and the severity of respiratory distress if it's there already. We have said that lots of glucose is being used because the metabolic rate increases, so that can cause hypoglycemia. So hypoxia, hypoglycemia, and acidosis because of this heat production, and the cold baby might then interfere with the infant's ability to use brown fat to generate heat. So it's almost a bad cycle effect. The baby needs oxygen. It uses oxygen and glucose to produce fat. And if he has depleted the oxygen, the available oxygen and glucose that's available, it can't produce heat anymore. So then obviously, as I'm saying, it becomes a bad cycle. And that is very important for us, for normal newborn babies, to keep them warm as possible, but specifically in the asphyxiated and the babies with already respiratory distress, this is extremely important. Now, there are some infants who have inadequate brown fat stores, and this is usually preterm infants because the brown fat usually is being accumulated around where they are being formed around the third trimester of pregnancy. So if the infant is being born before that, it's been born with inadequate stores of brown fat, and it can't adequately produce heat from the brown fat. And that also happens in intrauterine growth retarded babies because they also don't have enough brown fat stores. Now, hyperthermia is an equally big problem when the baby is too warm, because infants also respond very poorly to hypothermia. Because with elevated temperatures, their metabolic rate also increases. That again increases their need for oxygen and glucose, and also cause possible metabolic acidosis. The peripheral vasodilatation is, if in the first place, not sufficient, but that also leads to increased fluid losses, so the baby can get dehydrated very easily. Sweating may occur, but it's usually not also a normal activity, if I can call it like that, for newborn babies. So it might be delayed because the sweat glands are still immature. Now, the next adaptation that we're going to talk about is bilirubin metabolism. What happens with the bilirubin metabolism during birth and just after birth. Now, babies are not supposed to be born jaundiced because in the intrauterine period, the bilirubin is usually being excreted by the placenta and goes to obviously into the maternal bloodstream, and it's being excreted by the mother. So jaundice is not supposed to happen during pregnancy. If the baby is being born with jaundice, it's usually in the case of Rh negativity or other conditions that cause jaundice in the baby, and that, as I've said, is abnormal. Now, when we look at what happens now specifically with the bilirubin metabolism after birth, is normally in any body there are red blood cells that die down naturally and that need to be excreted somewhere in the fetus in the feces eventually. So what happens in the baby even more, in the fetus we've said that we have a so-called fetal hemoglobin that has a much higher affinity for oxygen than what our normal hemoglobins have. So after the birth of the baby, this fetal hemoglobins need to be broken off and it needs to be replaced by adult hemoglobins. So these red blood cells, these fetal red blood cells, if I can call it like that, need to be hemolyzed and need to be excreted in some way. So what happens is we find that in the blood stream, in the blood circulation, that we find that these red blood cells dissolve into heme and globin, which eventually forms biliverdin, which is an unconjugated bilirubin. Now, unconjugated bilirubin is fat soluble. And we will come to that, is very important. Now, this binds with albumin in the blood and goes to the liver to cause the conjugation of this unconjugated bilirubin. So in the liver, we get liver enzymes that helps to cause this unconjugated bilirubin to become conjugated bilirubin. Conjugated bilirubin is water soluble, so it can go into the biliary system and go into the gut system, the small intestine, large intestine, and it's then usually been excreted in the fetus in the form of urobilinogen, which is causing the brown color of the feces. And a little bit of this conjugated bilirubin is also being excreted through the urine, but that's usually a small quantity. So now what causes babies then to develop jaundice, and we call it physiological jaundice because it's a kind of a normal process. Now, first of all, in some babies, there's an increased production of bilirubin. As we've said, there's this now high hemoglobin concentration of the fetal hemoglobin that needs to be broken off and being replaced by adult hemoglobin, and that makes that there's more red blood cells that needs to be broken down. Also, in the case where there are some hemorrhages, for example, a cephalhematoma or some other bruising, where the bleeding has been, this hemoglobin blood needs to be broken down as well. So the hemoglobin which escaped out of this damaged blood vessels is now also rapidly broken down into bilirubin. And that might also cause then that there's an excess of bilirubin. Also infections. Usually in infections there's more hemolysis of the red blood cells, and that also causes more bilirubin, obviously, that needs to be broken down. And then hemolytic diseases in the newborn, and that's specifically in RH incompatibility. Other big problem or possible reason why babies develop a physiological jaundice is, remember we've said that the unconjugated bilirubin binds with albumin in the blood, and that enables the bilirubin, the unconjugated bilirubin, to go to the liver so that it can be changed to conjugated bilirubin and being excreted. Now, there's several reasons why there is a albumin deficiency in the bloodstream. The first might be that there's so much bilirubin that because there's not enough albumin, that there is a high concentration of unconjugated bilirubin. Now, some medications can also displace the albumin because most medications also need to bind with albumin in the blood in order for it to be taken wherever it needs to be done. And then other aspects also decrease the albumin binding of the bilirubin, and that's infections and acidosis, specifically when there was asphyxia as well, and free fatty acids also might cause that there's more that there's less albumin to bind with the bilirubin. Now, what is very, very important here is that, as we've said, unconjugated bilirubin is fat soluble, and they need to, as we've said, have to bind with the albumin to go to the liver in order to be conjugated. Now, if this unconjugated bilirubin is not being bound to albumin to go to the liver, they are freely moving into the blood, or moving around in the blood, and they move into the tissues and specifically across the blood-brain barrier, because the brain, the fat solubleness of this makes that it goes through the blood-brain barrier, and that can cause what we call Kern icterus. It literally means jaundice of the brain, and that can cause brain damage. Other factors that might contribute to the fact that the baby develops physiological jaundice is the fact that the baby's liver is immature. Remember, we've said that in the liver we use there's liver enzymes that helps with the conjugated process that makes change the unconjugated bilirubin to conjugated bilirubin, which is water soluble and can be excreted. So in some babies there's just too much bilirubin, and there's not enough liver enzymes in order to cause this process. And then also in preterm and late preterm infants, obviously, there's also not enough liver enzymes yet to help with the conjugation. Then intestinal factors also play a very important role, because we have said that when the bilirubin has now been conjugated into in the liver, it goes into the intestines, small intestine and large intestine, where it is being excreted, where it's been changed into urobilin, bilinogen, and stercobilin, which is in the way in which they are then being excreted in the feces. Now, in order for this to happen, in order for this change to urobilinogen and stercobilin, it needs intestinal flora. And the intestinal flora only forms when the baby is being fed. So if there's delayed feeding for some or other reason, the baby doesn't establish this normal intestinal flora to help with the change of the excretion of the bilirubin. So when feedings has been delayed or been taken poorly, then the flora has not been established, and we get an increase in this case, it will be conjugated bilirubin. Now, the next process of adaptation that we are looking at is the immune system. Now, before birth, the antibodies from the mother diffuse through the placenta into the fetus. So the mother forms antibodies against things that attacks her own body. Like we've said, for example, with the HIV that we have just done before, she produces antibodies against the HIV virus that goes through the placenta that will also, to a certain extent, protect the fetus. Now, the baby, after birth, the baby has not been able to form its own antibodies. It's a very slow process for the baby to form its own antibodies. So for a very long period after the birth of the baby has been literally relies on the antibodies that he gets from his mother. And in most cases, this antibodies can protect the baby for up to 6 months after the birth of the baby. Now, then eventually, gradually, these antibodies will disappear, and the baby will have to form its own antibodies, except obviously in breastfeeding, where the baby gets all the antibodies from its mother, and that helps to protect him against Now, seeing that the baby is not having a very good immune system, specifically if it's not receiving breast milk, one needs to be on the lookout for signs of infection. Now, unfortunately, fever and leukocytosis are not common signs and symptoms of infection in a newborn baby. A newborn baby never or seldomly shows increased temperature. But these signs are then more kind of reliable signs of infection, and then one needs to explore further. Lethargy or poor feeding is usually one of the two early signs of infection. Bradycardia or tachycardia, cyanosis or apnea, because we have said that in the case of infection, the baby also needs a lot of oxygen. Increased respiration or respiratory distress, and irritability. And these signs are usually, when they are present, one needs to explore further to see whether there are not signs of, they are not really in any infection. And that brings us to the end of these adaptations. And now it's again time for your quizzes. And I hope you've learned again something new.